So good morning, everyone. This is Tom Tersey from the Maryland School of Sailing and Seamanship, and we're very honored today to have with us Captain Lee Tucker, who is going to make a presentation on medical preparedness. Lee is a medical doctor as well as a 100-ton Coast Guard licensed master, and he has sailed with us for probably close to 20 years. And has done many of our training cruises, both in the offshore venue and also in the near coastal venue. And Lee began sailing on Chesapeake Bay more than 40 years ago. And since that time, he's completed about 90,000 miles of blue water ocean sailing in various vessels in the Atlantic, the Pacific, as well as the Caribbean. And he's an ASA certified sailing instructor. Certified to teach through all ASA levels up through ocean passage making. And Lee is an alumnus, actually, of the Maryland School's Ocean Training Program. I first met Lee almost 20 years ago when we were doing one of our early Bermuda training cruises from Norfolk to Bermuda. And Lee signed on as one of our student crew members. And decided he liked it so much he decided to do the round trip. He sailed back to Norfolk again after the outbound trip. So it was a very enjoyable time, and since that time we've had a lot of very close working relationship with Lee. And a couple of years ago, Lee did do one of our training cruises southbound from Norfolk to St. Thomas, and in that they practiced quite a bit with the sea anchor. And he did previously a webinar for us on storm tactics. So with that as a little bit of background, I'd like to ask Captain Lee Tucker to proceed with the webinar. Thank you, Lee.
Well, thank you, Tom, for that very nice introduction. Time flies, doesn't it? It goes by so quickly. Greetings, everyone, from sunny St. Thomas, more precisely, Water Island. It's a pleasure to be here this morning and to see so many sailing colleagues, both past and present, logged on this morning. This seminar is really an outgrowth of an interest of mine, or several interests, more precisely, that arose in the 108, the ASA 108 instructional program. When I would serve as instructor on one of the voyages, I increasingly became cognizant of the need for adequate medical preparations on board. So this seminar is somewhat of a outgrowth of those early preparatory seminars that I used to give in the 2 days that we had to get the crew and vessel ready for an offshore passage. A couple of housekeeping things. This presentation is being recorded and we'll have it available broadly for pay-per-view for those that can't attend today. But for those that are here, you'll find that there are some detailed lists of inventory items for medical kits, and don't panic and try to write all of this down during the presentation. We barely have time to go through it, in fact. It will be available online at no charge as a PDF. So by accessing the Maryland School website and going to the archives, you'll be able to download the PDFs that show the medical kit inventories. And so with that, let's begin. The first thing I wanted to mention, really, about the topic is when you pick up a standard book or text on offshore passage making or preparations for an offshore voyage, you will typically find a cursory mention of the medical issues pertaining to the voyage. Usually it focuses on first aid tactics, and in the last 15 to 20 years there have been a proliferation of seminars and also magazine articles that you may have seen in Cruising World or Blue Water Sailing, etc., that address or purport to address preparations for the offshore voyage, but mostly what they're talking about are the management strategies for emergencies that occur afloat and at varying distance from shore. What I find is lacking in most of these is a systematic review of what should be done, ideally, to prepare the crew as well as the vessel for an offshore passage. And so this presentation is meant to fill that void. What it is not is a primer on first aid or a medical response as would be expected of a crew member in the event of a medical emergency or a developing medical issue. That properly would be the subject of another webinar, and perhaps we'll do that at some point. By way of outline, I'll briefly discuss the difference between coastal versus offshore preparedness to put it in a proper context, because not everything that we're going to discuss today is exclusively the province of the offshore sailor. To be thinking about emergency versus non-emergent problems, there are a whole category of issues that arise at sea medically, either illnesses or injuries that are not emergencies but may develop into emergencies if we don't address them in a timely fashion. We'll spend some time discussing the crew, assessing pre-existing conditions as opposed to illnesses or injuries that might be acquired while offshore, and preparation strategies for the crew prior to departure, the composition and attributes of good offshore medical kits, resources that are available to the offshore sailor, as well as communication techniques and strategies for communicating with those offshore or onshore resources once you're offshore. Now, this will seem it's sometimes overwhelming, the degree of preparedness that is recommended here, but I want to put it in context. We would not consider going offshore in this day and age without an EPIRB or a life raft or a sea anchor. And so in that context, we should not go offshore without a medical kit and the training to use it, although we pack an EPIRB and life raft hoping that we don't use them, and at some expense to have that raft purchased and then repacked periodically. Same with the EPIRB. Battery changes are not inexpensive. So we shouldn't balk at the time and expertise and expense that is centered around developing a medical kit and the training and preparedness. In fact, you will, more likely than not, use a medical kit more often than you will either of the three items listed here. Obviously, there are a whole host of essentials not on this list, but I wanted to put it in context with some of the readily identifiable expense items that we think about today. Now, coastal, near coastal sailing differs from offshore sailing in several key attributes. One is the distance and the time that you find yourself away from qualified medical assistance. Are you able to alter course, as an example, to make port in an emergency for shoreside facilities? Or is the condition that you're faced with something that you are destined to manage on board? And what about medical evacuation? When is that an option? How do you make that decision? How do you prepare for that? Well, nowadays, the working range of most search and rescue helicopters in the United States, at least, is about 300 miles is the working limit. They're designed, in fact, for 300-mile each way in a round-trip situation with adequate fuel reserves carrying a crew of 6. The practical working range by the local search and rescue authorities might be less than that. It might be in the order of 200 nautical miles. And so, with that in mind, helicopter evacuation is not always an option offshore. In some cases, you have a protracted period of time waiting for a merchant vessel, perhaps, making detour to evacuate a sick or injured crew member off of your vessel. Another consideration in terms of preparing for an offshore voyage is the length of the voyage. It's clear that the longer the voyage, the greater the complexity of medical problems that will arise that have to be managed on board. This will in turn determine the amount and the type of medical supplies carried. And a longer voyage typically means you must have, a fitter crew with fewer pre-existing medical conditions. And longer voyages typically will require more comprehensive shoreside support when problems do arise. The next consideration is the location and the route of your intended cruise. The distance that you go from shore obviously reduces the number of options you have for medical facilities and rescue options, and especially when you get outside of the range of evacuation helicopters. But also, if you're fortunate enough to find yourself in the shipping lanes in the North Atlantic and Pacific, you might be fortunate enough to have a timely evacuation from a merchant vessel, but you may also find yourself in the Southern Ocean, as an example, where you are devoid of merchant vessels for the most part, and you find yourself more self-sufficient. Same too with polar and equatorial regions, which also raise the question, certainly in the equatorial regions, of endemic diseases that you don't have to leave your vessel to acquire, such as malaria and dengue fever, which dengue has been, it's a viral disease that's been endemic, meaning widespread, almost epidemic proportions in the Caribbean in the last 3 or 4 years. And an identification of potential ports of call in the event of an emergency should be considered. The type of voyage is often said to impact the type of injuries. This may be more urban myth than real, but nonetheless, I'll repeat it once again, that racing is said, and may indeed, raise the risk of traumatic injuries, if nothing else because of the tactics involved, the vessels involved, and the schedules that are faced with racing. Cruising may be potentially less dangerous than racing, but we're seeing older crews, obviously, and with an older crew population comes those with more pre-existing conditions. If your voyage includes diving of any sort, you have the risk of barotrauma and the prospect of decompression sickness to consider as well. Obviously, the type of vessel does make a difference in terms of the motion in a seaway and the comfort level, especially when conditions get rough. The cabin and deck layout will vary quite a bit, and you should consider how an injured crew member that may be injured in the cockpit or on the coach roof would be evacuated below decks or evacuated to a helicopter, given the rig and the specific logistics. Also, space is at a premium on a racing vessel. A cruising vessel has the potential of greater storage capacity for medical kits and, of course, the all-important ditch bag. Now, in thinking about the composition of crew, and I see post-it notes at the marina restaurants and dive shops and fuel docks and places like that wherever I go, looking for crew, short-handed couple perhaps, or a solo sailor looking for crew members to get the boat back somewhere. And there are a lot of unknowns, obviously, in putting a crew together. There are unknowns in among your own friends that you sail with. And so we're going to spend some time talking about crew composition and the characteristics of a good crew with respect to medical preparedness. Certainly, offshore sailing experience might reasonably equate with a greater competency or comfort with the sea motion, to the point of perhaps reducing some of the careless injuries that occur. Fitness level certainly does, and the number of crew does, in terms of whether you're sailing with a short crew that has a greater potential for fatigue and exhaustion when it seems a disproportionate number of injuries occur, or a fully crewed situation. The other aspect of the number of crew is if one of your crew members becomes debilitated, say due to a muscle strain in the back or a laceration in the hand, this cuts the number of functional crew down yet again. And so a short crew to begin with becomes a critically short crew after an injury. Do any of your crew members have comprehensive medical training that can be leveraged to provide expertise underway? And what about pre-existing conditions among the crew members? And we'll speak to those in more detail in just a moment. Now, not everything that occurs at sea medically obviously is an emergency. But as I mentioned earlier, a non-emergency that's allowed to grow and evolve can quickly become a medical emergency. And so because of this, we need to understand the difference between the two and why recognition and prompt intervention is important. Now, non-emergency conditions or non-life-threatening emergencies can be managed offshore adequately if you have appropriate training and supplies. But training and supplies are important. The training without the supplies is not effective, and the supplies without the training is not only not effective, it can be dangerous. Life-threatening events, once the individual is stabilized, usually would be rationale for medical evacuation. Now, let's talk about the crew composition for a moment. We really want to give some careful thought to pre-existing medical, dental, and psychological conditions, and it's been an evolution in the Maryland School to incorporate this, and those of you that have sailed recently with the school are familiar with the health questionnaire that is completed and verified by a physician. As the skipper or captain on your vessel, you need to know your crew. Those that present a higher risk, medical risk offshore, are any individual that is dependent on oral medications to manage epilepsy, a seizure disorder, and heart disease and all of its nuances, and those with organ transplants and those with severe asthma and diabetes. It's important to develop exclusion criteria for voyages beyond helicopter evacuation range so that you can apply a set of standard criteria. And I'm not suggesting that the individuals in these above categories be excluded from offshore sailing, not at all, but you should develop exclusion criteria that are reasonable based on your training, experience, comfort level, and the voyage and its attributes, proximity to ports of call. This can be accomplished through a self-declaration questionnaire. It can be signed or confirmed by the individual's medical doctor. And when thinking about the usual pre-existing conditions, don't overlook these items, which often are vision issues. And by this I mean peripheral vision, color blindness, and night vision are very important, and some of these are lost or diminished as we get older and are very important, obviously, for sailing offshore. Orthopedic conditions, either prior injuries, the necessity for braces, appliances, or restrictions in mobility and activity are important to disclose. Alcohol habituation is an important issue. I've had the fortune or misfortune, depending on your point of view, of having witnessed this firsthand in crew members who didn't fully understand that the daily intake shoreside was going to stop when we went offshore. And it takes about 24 to 48 hours for the withdrawal from alcohol to manifest in its fullest form, which can be a cause of debilitation of a crew member, complete with hallucinations and withdrawal symptoms. Giving alcohol, by the way, in that circumstance is not appropriate treatment. However, the crew member may request it. Psychological compatibility and mental illness are important to screen for. Finding yourself in a heavy weather situation with an individual with undisclosed panic disorder is a daunting prospect for the crew, and it's one of many compatibility issues that should be addressed. And obesity and limitations in mobility. I don't want to suggest obesity is the new normal, but the population does seem to be gaining ground in this regard. And obesity does have with it inherent risks for injury and limitations in mobility, so be mindful of that as well. Now, prior to departure, crew members should update their medical and dental checkups. Certainly, avoidable dental emergencies can be preempted with enough time prior to departure. This is not a good time to lose a filling or crack a tooth or have a dental abscess develop. Those on prescription medications should take a quantity sufficient for twice the duration of the trip, and this could also apply to non-prescription medications, but there may be difficulties in having prescriptions filled at distant ports. Immunizations need to be brought up to date, and I won't spend a lot of time talking about those, but I will mention tetanus in a moment. First aid training is important. Captains are required to have a basic first aid course every 5 years as a condition of relicensure, but actually that may not be accurate. It's an initial licensure, and I don't believe in most cases a renewal course is necessary, but it is important to have CPR techniques updated periodically as the recommendations on how to administer CPR do change from time to time. Immunizations need to be planned for with respect to the expected ports of call, and these can be this information can be gained from the Centers for Disease Control and Prevention website. www.cdc.gov/travel will give you the recommendations for any potential destinations. One that you should have, must have really up to date prior to departure is tetanus, because it's distributed worldwide, including sailing vessels and knives and instruments that can cause a puncture wound, and a booster dose is required every 10 years. And for a crew member that has never had a tetanus vaccine, 3 doses given at once are recommended for adequate immunization to tetanus. Tetanus is fatal, and there is no treatment if you contract it, so it's very important to be immunized. Now, in addition to this, this information should be disclosed and must be disclosed to the captain, and including limitations to activity, all pre-existing conditions, all medication use, and I like to have designated a formal medical officer or medic for the voyage. Now, in many cases, this would be the captain, but it may not be, and there are some reasons why it might be good to have someone other than the captain serve in this capacity. Insurance I'll talk about in a minute, but insurance is also a good thing to think about prior to departure. Many shoreside medical policies in the United States have specific exclusions overseas, and a policy that covers you in the United States may not cover you, say, in the Caribbean, as an example. But also evacuation insurance. There are quite a number of companies now that offer evacuation insurance. I've listed 4 of them. You can go online and research these yourself. Global Rescue is one, Travel Assist Network, Travel Insure, and MedX Assist. All of these offer evacuation insurance in the event of a medical emergency overseas, and will write a policy for an individual, a couple, or a family for as short a term, typically as a week, to annual coverage if you expect to be gone a lot or extensively. Prior to departure, then, it's important for the captain to introduce the crew to the ship's medic and to review the responsibilities this individual has and the direct accountability of this person to the captain. If this individual is not the captain, it would be by virtue of having special training and experience that would exceed that of the captain. The other preparatory conversation that needs to occur is a briefing of the crew on location and the contents of medical kits, and to review emergency response procedures. In other words, in the event of a lightning strike what are we going to do? Who is going to be on the radio if we have a person with a ruptured appendix? Who is going to be the first responder in the event that somebody is knocked unconscious with the boom, et cetera, et cetera. Go through emergency response procedures in addition to those typical emergency response procedures we talk about prior to going offshore, such as crew overboard recovery and abandoned ship procedures. Who is going to be the primary radio contact person? And when should we use the Mayday versus the pon-pon? Now, we're all pretty clear that Mayday is reserved for imminent loss of life and limb. But a pon-pon is a valuable adjunct in the event of an evolving medical problem, not an emergency, but it will help you identify those vessels in proximity that may be able to relay a message or relay a Mayday or come and render assistance in the event that you need it. Now, the designated medical officer is typically that crew member that has the most comprehensive medical training. This person is provided with the confidential health status of the other crew and becomes familiar with the onboard medical kits, their inventory, as well as the onshore resources that have been established for the voyage. This person also would be the one to conduct the pre-departure crew orientation and training, and of course reports directly to the captain, if it isn't indeed the captain. Now, underway, there are a number of medical conditions that are acquired that I'd like to briefly address, and although I'm not going to speak to emergency response measures, these are more to give you the background and the mindset as we go forward and talk about some of the other preparatory steps that we make. With any evolving medical condition, whether it is a medical illness or a traumatic injury of some sort, our first goal, of course, is to prevent it. It's a lot easier to prevent most of these conditions than it is to remedy them. But when they do get started, to recognize them early as being a departure from the normal baseline state. And it may be a subtle thing in some individuals. To arrive quickly at a correct diagnosis, either with onboard resources or resources ashore, and then to effectively manage the problem without inflicting injury. Seasickness may be the most common acquired medical illness, or certainly the first one encountered by the crew going offshore. We vary quite a bit in our susceptibility. It's important to have prevention strategies and also a treatment plan once we have affected crew members. Now, some of this information I'll be referencing Beth Leonard, who had a nice article in Cruising World in September 2010. I think most of us would agree that nearly all offshore sailors are susceptible if conditions are right. In fact, many times the one member of the crew that I see that does get seasick is the one that says prior to departure, well, I'm not taking anything for prevention. I never get seasick. It never bothers me. And then once out into open water, that sailor succumbs. It's most often the case that day 1 to 3 offshore is when a sailor is going to be susceptible, and most will adapt after 3 days in spite of what we do or what we don't do. Symptoms are variable and idiosyncratic with the individual, but they're progressive in just about everyone that gets it. And even though they're idiosyncratic to the individual, there are some generalizations we can make. The majority will be manifest by nausea. About half will vomit. About a third have drowsiness or lack of mental acuity, and this is especially dangerous in that first 3 days offshore when we're getting adjusted to the boat and to sailing conditions and to gear and each other. And about a quarter will report fatigue and lethargy. In the great majority, 86% in a limited survey by Beth Leonard, the symptoms were progressive and unremitting. and in fact, if untreated, led to intractable vomiting. And of course, the danger of that is dehydration and the debilitation that comes from dehydration. And about 14% were seasick, then recovered, felt better for several hours, and then relapsed. Those seem to be the two patterns. Now, Beth's accumulated strategies from this survey of seasoned, experienced offshore voyagers boiled down to basically 10 strategies. Some sound a little bit like folklore, some certainly are proven. The first is to do as much as you can before departure, and this just makes sense. Rig lee cloths, get the navigation plan buttoned down, lash the storm trysail to the base of the mast, lash on your jerry cans on deck, do all the things that you should do and can do prior to departure so you're not faced with those when you're first offshore. Avoid alcohol for 48 hours. This may be hard for some, but it's going to be especially important because the effects of alcohol do linger for about 2 days after imbibing it. And take preventive medication 12 to 24 hours prior to departure. This depends a little bit on the medication. Some like to acclimate with day sails or anchoring off overnight in a rolling anchorage 1 or 2 nights before departure. The thought is they're getting a head start on that 3 days of conditioning. Set up the vessel to limit time below decks. Well, there's certain items that you just have to do below decks, like the boat checks and log entries and such, perhaps some navigation, but you can set the boat up to minimize the amount of time you need to be down there. And to avoid triggers, fumes, smoking, fine visual work like reading and sewing. Sew your sails up before you leave. Save your reading for once you've adjusted. And eat and drink in small amounts. A large amount of gastric distension seems to be a trigger in some people for nausea and vomiting. So eat and drink, but do so in small amounts. It's very important to recognize and treat early symptoms. And for that, you need to know what the early symptoms are. And some of the earliest ones are fatigue and yawning, a mild generalized headache. This is followed a little later by increased salivation and increased swallowing and possibly belching. Get on deck, take the helm, take medication. This is prudent advice. It's been well proven. Get some rest. Some prefer to sleep if all else fails. Offshore, you should try to get as much sleep in the bank early on, for you never know when rough weather is going to require more crew participation. And prevent a relapse from occurring. And an example of this would be if the weather deteriorates, retake the meds 12 hours before the weather deteriorates and try to prevent it if possible. Now, dehydration, I mentioned, is one of the significant adverse outcomes of seasickness. It's best to avoid it by drinking in small quantities, drinking fluids and electrolyte solutions, things of that nature, juices. The difficulty comes in recognizing you're dehydrated. It sneaks up on you, and by the time you're thirsty, thirst is actually a relatively late sign of dehydration. We don't typically understand that, but by the time you're thirsty, you've lost perhaps 5% of your body fluid, and so dark-colored urine or a failure to urinate is certainly a sign of dehydration. But if you urinate and urine is not champagne-colored but is orange or amber-colored, then you have a measure of dehydration. Obviously, the simplest thing is to take fluids by mouth, but it may be necessary in order to keep something down if you have a crew member who's very nauseated with seasickness and can't even keep seasickness pills down. Phenergan 25 milligram suppository is very effective in controlling nausea and will allow you to mitigate the nausea and the vomiting enough to rehydrate the person. Another category of acquired illnesses at sea that are problematic are infectious diseases. Now, most of these are relatively minor, skin irritations, rashes, small abscesses, things of that nature. Gastrointestinal disturbances, constipation, or diarrhea certainly occur. Respiratory illness, especially viruses that are acquired offshore but unknown to the individual that incubate, may be manifest a couple of days offshore and may be quite severe. Issues with the urogenital tract in older men, bladder retention, sudden bladder retention and complete inability to void is an emergency. Vaginal infections, corneal abrasions, eye irritation from exposure to the elements, ear infections, etc. All these are developed with some frequency offshore. Exposure, hypothermia, a failure to bring or wear appropriate layers and foul weather gear are avoidable. The management of hypothermia depends on understanding its presentation and differentiating mild from severe hypothermia. Mildly hypothermic individuals shiver as a response to generate body heat, but may have diminished judgment and ability to speak and may slur and appear drunk, whereas severely hypothermic individuals may collapse, may be profoundly uncoordinated, uncooperative, incoherent, and are at risk for cardiac arrest and respiratory arrest. Never, ever give fluids or anything by mouth to anyone that has any degree of hypothermia beyond mild hypothermia. And in all cases, never massage the extremities or give anything that will cause vasodilation of the extremities, either hot water bottles or alcohol, because the peripheral vasodilation only reduces the core body temperature by shunting blood from the core out to the extremity where it's readily lost. Notice that both in the individuals in this picture do not have adequate head protection. It is estimated that 20 to 25% of the body's heat is lost through the head because of the rich blood supply around the skull. And so an appropriate and effective hat is important in conserving body heat. Also, exposure to water. Water conducts water away from the body 20 times faster than air, and immersion or exposure to the elements, rain, sea spray, and wind, are effective ways of inducing hypothermia in an individual. And you're no doubt familiar with this chart that shows that it's not only the duration of immersion in water, but the water temperature that predicts not just the development of hypothermia, but as you can see in this chart, the probability of death. So this is an important issue offshore. Allergies are not typically acquired offshore. They may occur offshore. Allergies may be with us but unknown to us, or we inadvertently eat something that has an allergen that we knew or did not know we have. But also medications, either medications a person is self-administering or from the ship's medical kit, may induce an allergic reaction as well as various bites and stings. Now, an allergic reaction is one of the few things that can kill you in a matter of minutes. And so we must have an appropriate strategy for addressing allergies. Cardiac emergencies, cardiac arrest, and arrhythmias need to be evaluated with a planned emergency response, as well as seizures that occur on board. Fortunately, most of the injuries that we see offshore are relatively minor, but some are not. Burns occur with some frequently, and I'll spend some time talking about those, as well as injuries to the head, scalp, and neck. Cuts and abrasions and lacerations are common. Fractures, although not common, are serious. Dislocations are more common and exquisitely painful and potentially debilitating to the crew. And of course, sunburn is another form of injury that we see with some frequency. This is an image of a particularly bad rope burn that a sailor sustained, and these of course are completely avoidable by use of proper line handling techniques and sailing gloves or sailing gloves. But galley burns are more common underway and offshore because of the conditions that we're in. But don't forget, work on the engine or the electrical system can also cause a very nasty burn. Now, the burns come in several varieties, and these are important because if you have an individual with a severe burn or a burn that is in need of treatment, and especially with a shoreside facility, one of the questions you're going to be asked is how severe is the burn? Is it a first, second, or third degree burn? Well, if the skin is black and charred and the burn is not painful, it is a third degree burn. The nerve endings in the skin have actually been burned away. And so paradoxically, the worst of these is a third degree burn. It's very prone to infection and to fluid loss. And so it's a cause of dehydration. The difference between first and second degree burns is a matter of degree. Both are extremely painful, as you are well aware. The distinguishing feature of the second degree burn is blister formation. A lot of burns occur in the galley because of scalding water, water used to boil vegetables, rice, hot water for tea or coffee, and a splash can cover a large part of the body. It's important in sea conditions to wear foul weather gear, bib overall, or even atop the jacket when cooking in the galley, and a galley belt. This is a typical flat or slightly raised first-degree burn. It's not blistered or charred. This is a second-degree burn. You can see on the hand it's a large blister and a large area that's reddened. On the left panel, you can see a large area of the arm where the blister is unroofed, and these are quite painful, and they're prone to infection, and they lose a lot of body fluid. Electrocution, obviously, is another cause of burn injury, but the most serious thing that can happen, because our cardiac rhythm and our respiratory drive are both driven by electrical impulses. They can polarize the conductive system in the heart and in the drive to the diaphragm and cause cardiac and respiratory arrest. So the first response in a lightning strike, direct strike to the vessel, is to check crew members for breathing and heartbeat, for vital signs, and then assess for burn injuries, among other things you will do with the vessel. But the crew member first needs to be assessed in the event that CPR or rescue breathing is going to be necessary. I think it's safe to say that if an injury can happen on shore, it can and probably will happen offshore. Common sailing injuries were reported in a survey in the Journal of Wilderness and Environmental Medicine. I'll give you this reference in the event that you want to bring up this reference and read it yourself. 2010, volume 21, by Andrew Nathanson, who conducted an online survey over a 6-month period and asked for self-reporting of injuries and illnesses covering the previous 12 months of sailing experience, and 1,188 sailors responded from all types of sailing experiences and backgrounds. So this is not meant to be a report of injuries and illnesses that occur strictly offshore on keel boats, but it is of value nonetheless because there is mostly anecdotal information available. There's very little literature that is based on any kind of a survey or statistical analysis. So this is typical of the handful of recent studies that have been published. 1,700 injuries and 559 reported illnesses. Now, in his study, just to give you background of the makeup of the respondents, 71% of the injuries occurred on keel boats, 23% on dinghies, 4% on catamarans, a few on windsurfers and other vessels. And this doesn't mean that keel boats are the most dangerous. This is just to give you a view of the spectrum of responses. Now, of those keelboat injuries, almost half of them occurred in the cockpit. Now, this would have to be taken in the context of where you spend most of your time, because if you spend 10% of your time in the cockpit and yet half of the injuries occur there, the cockpit would appear to be a dangerous place. But if you spend 80% of your time in the cockpit and yet only 46% of the injuries occur there, then it would seem that being below decks is more dangerous. So be careful when you see this kind of information and ask the question, what kind of conclusions, if any, can be drawn from this kind of information. There were some bits of information, though, that were valuable. One is that racing in itself was more likely to be associated with head injuries, and cruising, although it's not very exciting, trip and fall injuries accounted for about 1/3 of the total injuries among the cruising population. Most of the injuries were minor. 11% were leg contusions, which are deep, typically painful bruises of a muscle that may be associated with some hemorrhage or hematoma, either under the skin or within the muscle. But 8% were hand lacerations, 6% were contusions to the arm. Now, there were quite a number of serious injuries reported, and 25% of those were fractures or broken bones. 16% were muscle tears, typically of the legs, arms, and shoulders. But 14% were concussions, and most of these were from being struck by the boom. And 8% consisted of dislocations to the fingers and shoulders. The common mechanisms of injury in his study were trip and fall injuries, being struck by an object, such as a whipping line or a boom, as an example, or being caught up in lines and tripping and getting tangled and falling. The circumstances of these injuries, not a surprise perhaps, but it's worth restating that tacking and jibing are dangerous, and an otherwise intact, healthy crew can come through a tack now with a new injury. And so it's a sobering thought to be careful with either of these maneuvers and to jibe under control. Heavy weather, of course, because of the sea state and the accelerated motion, exaggerated motion of the boat, was also in the top 3. Here's an example of an open fracture. An open fracture differs from a closed fracture by virtue of breaking the skin. The fractured bone may actually be visible in the wound, but it does not need to be visible to be considered an open fracture. An open fracture is especially vulnerable to infection. A rib fracture is also common from being thrown about in the cockpit, hitting combing, hitting a winch in a tack or a jibe. Below decks, being thrown across the cabin either in a capsize or in a tack. So it's always good to alert the crew of a potential or an imminent tack or jibe, except in the middle of the night when everyone is safely put away in their berths with lee cloths. But a rib fracture is diagnosable by being painful, exquisitely painful, with some swelling, and there may actually be some palpable abnormality over the afflicted area. A dislocation is not a fracture, but it's the result of a forceful injury, usually to an extremity or to a major joint, where the ligaments that hold the joint together are stretched beyond their normal limit. And so there's an injury to the ligament typically, as well as possibly the musculature surrounding that joint. And it's exquisitely painful and associated with a visible deformity of the affected joint. You can see in both of these pictures the third finger on the left and the index finger on the right are both deformed. These would be both exquisitely painful, as is the middle finger in this case. And you don't need to have an X-ray machine on board as a crew member to make this diagnosis. A deformity of this type is going to be a dislocation. It's reduced, the term is called reduction, by hyperextending the joint and allowing the ligaments to basically pull the extremity back into place. And then it's secured with a splint, and don't forget the pain medication. A shoulder dislocation is also exquisitely painful and will result in disability of the crew member, not only until it's reduced, but sometime thereafter because of the pain involved. It's recognizable by a deformity as well as pain, and comes in several varieties, anterior and posterior dislocation, depending on the motion that caused it. Some individuals are prone to dislocations. They've had them before, and if your crew member says, I've had my shoulder dislocated before, they're at risk for having another shoulder dislocation. The reduction is simulated in this photograph, shows basically the one crew member pulling on the arm while the other has a large triangular bandage around the trunk to immobilize the body while the shoulder is pulled and then released back into position. Quite painful. Now, cuts, laceration, and puncture wounds are fairly common injuries on board, and deep laceration is certainly cause for concern. It can penetrate the skin and fat and extend down into the muscle of the affected area. A laceration differs from a puncture wound primarily in its configuration. A puncture wound may not be deeper than a laceration, but it's a narrow opening that tends to close, and because it is so narrow and it can actually seal off on the surface, it can harbor infection more readily, especially organisms that don't require oxygen. These are called anaerobes, and anaerobic infections can be extremely dangerous. Clostridia tetani, or the tetanus organism, is an example of an anaerobe that develops in puncture wounds, and why it's important to have tetanus immunization. Now, dealing with these is a matter of the expertise you have on board, and again I see the recommendations to carry a suture kit and carry a staple gun for closing the skin. If you've never used these devices, it doesn't make sense to carry them offshore unless you have a crew member that's trained in their safe use. So my first qualifier here is carry them if you have the training and experience, or you have a crew member that does. Failing that, then we have the option of using steri-strips. Suturing is not best learned underway. It's best learned either in one's occupation, or there are a number of emergency and wilderness type medical training courses running from a weekend to a week in length. I'll give you some resources for these at the end of the talk, where you can learn to sew up skin like a pro, and you can get something like this, which is a laceration. Actually, it's an avulsion injury, a blunt injury on the wrist, which tore open the skin and subcutaneous tissue down to muscle, and it's closed very nicely with what we call an interrupted stitch. Here is an example of a healing suture line in the web of the hand between the thumb and the index finger that has been closed. It's important to know that you have no more than 24 hours after such an injury to suture, staple, or steri-strip it closed. If you wait longer than that, there is a high probability that wound will become infected, or is already infected, and you don't know it. And by suturing it closed, you're creating the high probability of an abscess developing in that area, which is a much more difficult medical issue to manage than a laceration or a cut. So if you're going to close a wound of this type, close it early with good technique, and perhaps in a subsequent webinar we'll go into more detail. Now, for those of us that are less skilled in wound closure with staple guns and sutures, steri-strips by the 3M company, and there may be others now available, can be used effectively to close small and some reasonably large cuts and lacerations as well. Here's an example of one on the lower leg and also on the thumb that have been closed with steri-strips, and you don't have to be shy with the number of these that you are using. Whatever you can do to close the wound, to effectively bring the edges together to control the bleeding, and also to protect the wound so that antibiotic ointment can be applied and healing can be achieved by the application of a dressing. The common threads in injuries seem to be the use of alcohol that blunts the reflexes, takes an exercise in slicing onions and turns it into a laceration of the finger, poor communication among crew members, and in the case of hypothermia and falling overboard, the non-use of PFDs. So in terms of prevention, obviously safety and safe practices are important. Appropriate galley safety, I mentioned a couple of items there. But onboard medical kits are the mainstay and for the response to injuries and illnesses on board. And with these, I like to have not only a comprehensive ship's medical kit, but also smaller satellite crew member kit or kits available for general crew use. Obviously, the EPIRB is an important adjunct in the event that a medical emergency exists that will require assistance where it cannot be obtained otherwise, or for medical evacuation, and in a prior identification of remote resources and the establishment of a relationship with them, and of course communications that allow you to communicate with those remote resources. Now, in terms of injury prevention, it's common sense that below deck lockers are secure, that they can't open in a active seaway. Some even go so far as to have them all lockable so that in the event of a capsize, the lockers don't open and spill their contents. Safe practices in the galley, using precautions with water, oil, fire, and galley belts and foul weather gear, lee cloths, of course, stowage of personal gear out of the way, safe winch and line handling techniques, prevention of accidental jibes, and of course using jack lines and tethers and keeping the cockpit free of extra lines and such that pose trip hazards. So now let's talk about the medical kits that we'd like to have on board for use. As I mentioned, I'd like to have crew members' kits that are available for the common necessities that the crew can directly access, with a comprehensive ship's kit reserved for those more substantial emergencies or more complex conditions that arise, but also as a means to replenish the crew members' kits on occasion, as well as a dedicated kit for the ditch bag in the event that you find yourself abandoning ship. Now, in terms of the attributes of a good kit, irrespective of the type of voyage that you're on, I think it's important that it meets the needs of the crew. With all the things we've talked about, pre-existing conditions, potential for acquired conditions underway, reflects the type of sailing planned. Do you expect to be racing or cruising, perhaps an older crew? Should be arranged according to the body system so that there's a logical sequence and organized for each practical procedure. So you're not just digging through one big bottomless bag to find one item. It should be user-friendly for the novice who's not perhaps an expert in identifying materials, and have a quick access layout plan so that when you do have an emergency, you can go right to the item that you need. And having said all of that, it should be reasonably compact with robust and light containers that are waterproof and preferably airtight. Now, these are available commercially. You don't have to put your own together, although you can customize it, and I typically recommend that for the characteristics of your voyage and your crew. But these can be purchased in various sizes, not only through the well-known chandleries like West Marine and Budget Marine and those organizations, but also the medical evacuation and shoreside support facilities that offer support for cruising sailors. This is an example of one that's nicely organized into packets for CPR instruments, fractures and sprains, burns, wound care, bleeding, etc. The individual crew member's kit, it could be one kit available for the entire crew, would be an example of this, or strategically located in a lavatory or a common area. And we typically have the simple painkillers such as ibuprofen, aspirin, acetaminophen, adhesive bandages, and topical antiseptic, sore throat lozenges, sunscreen, seasickness medications would be an example. The commonly used things that are typically rapidly depleted. Now the ditch bag kit doubles as an emergency treatment bag, but we try to stay out of it for obvious reasons, so the contents are there when we need them. Here again, the emergency painkillers, seasickness medications, a variety of these for up to 6 people, obviously, in the raft, an array of antibiotics, rehydration salts that can be added to the drinking water to replenish electrolyte and glucose. A suturing kit, again, assuming that there is the sophistication to use it. An alternative would be the skin stapler, which requires less skill. And the alternative to that, of course, would be the steri strips. A variety of splints and bandages, and duplicate crew prescription medications in the event that your crew member couldn't get into the raft and grab their prescription medications on time. So another reason to disclose all medication use to the ship's medic. Now the ship's kit is the comprehensive kit that would reside on board, and the contents of this kit really depends on the type of sailing you're going to do and the amount of expertise on board and your personal philosophy. I'm not going to make blanket recommendations that are hard and fast rules, but that common sense and your experience, which is increasingly informed experience, will give you the comfort level for carrying some of these items. However you do it, a large stores bag is typically a good idea for infrequently used or bulky items. You will want to carry large splints for either entire arms or legs. You may want to carry bags of sterile intravenous fluid if you are going to administer IVs, and again, that is an if, not a must. Stiff neck collars for cervical spine or neck injuries or dislocations. Replacement medications for your medical bag. And these last two items, again, are optional depending on your preference and the type of cruising you're going to do. An oxygen cylinder and a defibrillator AED. Now, I'll spend some time talking about both of these because they really they are somewhat controversial, and it's hard to make a hard and fast recommendation. Now, an oxygen cylinder is typically found on an airplane, as is a automated defibrillator, but that doesn't mean that it's necessary or recommended on a sailing vessel. There are times when oxygen administration can be comfort-giving and potentially life-saving. And certainly in diving accidents, if you're doing a lot of diving, that might be a recommendation for oxygen. But it's not just a matter of carrying the cylinder. You also have to carry with it a pressure regulator, adequate tubing, and face masks in a variety of sizes to go with that. IV fluid, again, is another item that you have to have somebody on board with the expertise to perform venipuncture, to get the IV started, to check it periodically, and to know when to administer IV fluid and when to stop IV fluid. Obviously, it's a way of rehydrating a profoundly dehydrated crew member, and it is an alternative means for administering intravenous medications, which you may or may not be carrying. If you do carry intravenous fluid on board, you have to not only have an assortment of IV catheters, which are sterile, and their sterility has to be maintained and their out date observed, but the dressings for the IV and the administration sets, which you connect to the needle, between the needle and the bottle or the bag, typically a bag of IV fluid. And many recommend if you carry any at all, you might as well carry between 5 and 10 liters of ringers, lactated ringers, or normal saline, or both. So it's a big commitment to carry all this material. A defibrillator is likewise controversial. Now, I have seen situations in coastal sailing where an AED has saved a life, and it happened just last year down here in St. Thomas, where a gentleman on a sailboat had a heart attack, or he had an arrhythmia, and coded, and the vessel happened to have an AED on board. They cardioverted him back into normal sinus rhythm and transported him ashore, where a waiting ambulance took him to the hospital. Now that is terrific, and that has provided the recommendation that an AED be carried on board. And certainly for a lot of vessels that spend a lot of time in coastal and inshore environments, that can be justified. But there is no data yet to show that if you're in an offshore situation, let's say outside of helicopter evacuation range, and an individual goes into ventricular fibrillation and you cardiovert them with an AED, that you're actually going to be able to save a life, because you don't have the prospect of timely transport of that individual to a facility that can give the full support necessary in that environment. So although in theory it's great to think that you may be able to cardiovert someone, the reality offshore is that it's not proven effective yet. So if cost and space are no option, you may want to do it and learn how to do it, learn how to administer cardioversion with one of these devices. But remember that you have to take along some accessories, the monitoring electrodes, the conductive pads, and maintain a service record, a log of service for the defibrillator to make sure that it's properly within dates. The kits should be customized for your voyage. Now, getting beyond the large gear bag to the core of the contents, the considerations here are the duration of the voyage, the number of crew you have, and also the type of crew. Is it all men? Are there men and women? Are there children involved? Is the voyage a racing trip primarily, or will it be cruising as well, or exclusively? And is the route more remote? That equates to greater self-efficiency. And how much medical expertise on board do you have? Obviously, the more expertise on board, the more sophisticated the medications and the accessories are, such as suture kits. The medical history of crew members is important, obviously, and whatever opportunities exist for resupply in ports of call. These characteristics are why a definitive list with volumes and quantities can't be articulated at this point in time, but I hope by doing this I'll give you at least the framework to think about what would be appropriate for your offshore passage. The contents of the kit can be broken down into categories, and this slide begins a list of, I think the next 17 slides are lists of contents or inventory lists that will be available to you in PDF form from the website at some point after the presentation. There are items that are germane to first aid, emergency allergy issues, burns, dressings and splints, dental emergencies, and then various forms of equipment and medications. The first aid are the commonly needed items that go beyond the crew member's kit. Of course, redundancy and adhesive bandages, adhesive skin tape, sterile gauze bandages in various sizes and rolls. Liquid skin, which can be painted on, forms a membrane-type barrier and it has a built-in antibiotic for minor cuts and abrasions. A topical antibiotic ointment, such as a betadine solution. Disposable scalpel, aspirin, acetaminophen, ibuprofen, antacids, Zantac, example, monostat for vaginal yeast infections, tinactin powder, and Lamisil for topical application for fungal infections. So these would be fairly common items of first aid, which would be also used, some of the items, to replenish the crew kit. Now, as I mentioned earlier, allergies can present as one of the imminently life-shortening emergencies on board in terms of a developing catastrophe. And with that, you need to have sufficient means to address an allergic reaction, the cause of which you may not know. And so what we're talking about here really is a symptomatic treatment of allergy, which gets at the underlying mechanism, but you don't know necessarily what the cause is. Albuterol inhaler for bronchospasm relating to asthma. Benadryl in various forms. The liquid is readily absorbed and is rapidly brought to the systemic circulation for a generalized allergic reaction, such as hives. The lotion is effective in the topical treatment of a sting or an insect reaction. The tablets obviously are slower to absorb but longer lasting. For an acute anaphylactic reaction, epinephrine is life-saving. And with that, it comes in what is now called the Epi-Easy pen. It's an injectable, self-administered, or a crew member can administer it to you, 1 to 1,000 dilution of epinephrine. Prednisone tablets for longer-lasting immunosuppression for allergic responses, and hydrocortisone cream, which is applied topically to the skin, 1%. Nitroglycerin is not here for allergy purposes, but for symptoms of angina or chest pain relating to coronary artery disease. Now, burns are important for several reasons. One is that they become infected. Second, they're debilitating and painful. Third, they lose a lot of fluid. And fourth, if they're severe and widespread, they can be life-threatening. And so it's important to have an antiseptic cleansing solution to clean the skin, and silver sulfadiazine cream. This is a big tub of it. 400 grams is almost a pound. This is an antibiotic cream that is protective, and depending on how extensive the burn is, you may need that much. Paraffin gauze dressing is a non-sticking dressing, as are the burn dressings that can be applied over the burn, and sterile saline also for rinsing the burned area. Now here's a list of dressings and splints. I'll just mention a couple of these things specifically. The first is the non-adherent sterile dressings. These have been a great advance, and I highly recommend them. They go by a whole number of different names: Telfa, Adaptic, Xeroform, Aquaphor. There are probably half a dozen other brands out there. These membranes are basically a gel that is 96% water. They're permeable to air, but they keep fluid and dirt off of the wound. And the great thing about them is they can be applied and left in place over a large wound for 48 hours or so before they're changed. So they're handy to have on hand. And then you'll see the usual list of gauze pads and rolls, and steri-strip, triangular bandages, finger, arm, and hand splints, as well as leg and thigh splints. Under equipment, I've listed first aid and medical manuals. This is very important, and I'll give you some nice references on half a dozen first aid and specific medical manuals specifically written for sailing, and some of these for sailing offshore, some of which you'll want to have. In addition to that, you do need some instruments. Toothed forceps and tweezer forceps are very handy. Scissors, of course, bandage shears, skin stapler or sutures, depending on your expertise. Syringes and needles are used for irrigation of wounds. primarily, magnifying glass for a whole host of things, including removing small foreign bodies from the eye, and sterile as well as non-sterile gloves in various sizes. It's important to be able to irrigate wounds to cleanse them, and so for that, hydrogen peroxide, 70% alcohol are added to the list. Alcohol and betadine swabs for local antisepsis, and a 10% betadine solution for wound cleansing and irrigation, as well as sterile saline. And a lidocaine, 1%, 5 milliliters, is recommended if you will be suturing or stapling the skin. And that would be administered with the suture and needle that I mentioned previously around the edge of the wound so that suturing can be relatively painless. Dermabond is a skin glue. It's basically a methacrylate resin like super glue. For minor cuts, it's useful. Clean, small cuts and lacerations can be used to reapproximate the skin edges and accelerate wound closure. I think it's prudent also to have a Foley catheter. These come in various sizes. A 14 or 16 French is a catheter that in the event of acute urinary retention, this is effective means of draining the bladder. It's good to have a drainage bag for the catheter to flow to. Stethoscope and blood pressure cuff. Thermometer, it's important to have. Now, comment about the thermometer, the range should be a low of 85 for hypothermia assessment to a high of 107 for obvious severe fevers. And if your thermometer doesn't make that range, get a couple of them or use a digital thermometer that has that range. Typically they will. Urinalysis test strips, airways, a pocket face mask with a valve for CPR administration, pregnancy test kit, foil blankets, and an angiocath in the event that you have trained crew able to perform tracheostomy. Now, an angiocath is basically a needle, a big needle. A tracheostomy is a hole in the throat used to bypass an obstruction in the upper airway around the base of the throat or around the thyroid area. It's important that this only be done by individuals that are trained to perform a tracheostomy, not something that you read about in a book while your crew member is turning blue. How often does this come up? Well, probably not as often as some people would believe. For one thing, it's important to know that a person not able to breathe who's gasping for air may not need a tracheostomy. They may need a puff with a albuterol inhaler, because asthma, which will have very much the same symptoms, will not be relieved by poking a hole in someone's throat with a needle. That requires relief of the bronchospasm in the lungs themselves. So I'm very, very hesitant to make any kind of a blanket recommendation for emergency tracheostomy absent appropriate training, and that training must include diagnostic certainty. Remember, first do no harm, and you can do a lot of harm by pushing a needle into the middle of somebody's throat. So that having said, we'll move on to the dental kit. Important to be conversant with some of the problems that occur with teeth underway, and one of the primary is losing a filling and having a painful cavity exposed to air. There is a material called Cavit, which can be molded and pressed into place as a temporary filling. Eugenol oil is an anesthetic that is very effective in the oral cavity, oil of cloves. And you can make a nice temporary filling material by mixing oil of cloves with zinc oxide. And by making a putty of this and applying it to the affected tooth, and this could be also a broken tooth or tooth that has fractured one of its cusps, maybe weakened from a previous filling. This can not only provide a temporary restoration, it hardens on contact with saliva, but is effective in pain relief as well. The kit should include a variety of seasickness remedies. Different things work in different people. The lower echelon drugs, and by that I mean the potency and effectiveness, are for mild to moderate seasickness, are bonine, dramamine, and antivert. Stugeron is typically available overseas, but not in the USA or Canada, is said by some to be more effective for them. More effective still is scopolamine, either the pills or the patch. Phenergan is not a seasickness remedy per se. It does nothing for motion discomfort, but it does control the nausea. And for many people, the nausea and vomiting is the worst part of seasickness. So giving a Phenergan suppository will relieve the most objectionable aspect of seasickness. The individual may still have the fatigue and the mental fogginess of seasickness, but not the debilitating effects of dehydration. Because Phenergan especially is sedating, scopolamine less so, pseudoephedrine or Sudafed is recommended, especially with Phenergan, to counteract the sedating properties of that drug. And so I put Sudafed on here not because it's a great nasal decongestant, which it is, and it's good to have for that reason, but also for the reason that it counteracts other meds. Now, the common things, of course, with the GI tract relate to diarrhea, constipation, loss of fluid and dehydration, and indigestion and heartburn. And so the medications in the GI kit are targeted for those conditions. This seems to be a long list of antibiotics. There is a middle ground to be struck here, and I think in the realm of antibiotics, less is more. Let me say that first as an overarching principle. It would be a good principle to select the fewest number of antibiotics that do the best job offshore. Now, this is a more inclusive list because I've tried to err on the side of inclusion rather than exclusion, but in principle, the best single antibiotic that you can give would be the one to carry, and the one that covers the most problems. So we have a matrix here of not only body sites that are being treated, such as urinary tract versus skin versus abscess, but we also have different types of organisms to be treated. So it's hard to say, well, one or two or three are going to do the job. And then we have the issue that penicillins, and their representative here would be amoxicillin, well, some people are allergic to that. So you have to have a second-order drug for those people that might not be as effective or the first choice, but for those minority of people that are allergic, will be the drug of choice for them. And so this list is meant to be more or less inclusive of the issues of infectious disease that I covered earlier in the presentation, with a couple of nuances that I'll just point out. Halfway down you see sulfa-trimethoprim. This is really, its best use is for urinary tract infections. Penciclovir cream, the next one down, is for sunshine-related herpes simplex and the painful blistering that occurs on the lips, can help address that. Fluconazole or diflucan for persistent or virulent vaginal yeast infections not treated with monostat. Obviously not necessary if you have an all-male crew. For eyes and ears, I have a couple of antibiotics there, one for the eyes, Tobrex, and the other cordysporin for the ears, cordysporin otic. Bactroban, which is second to the bottom, is an effective topical antibiotic for the skin, and clotrimazole cream, an antifungal. Now moving on to painkillers and analgesics, there's no limit to these, obviously. I've listed the big three: aspirin, acetaminophen, and ibuprofen. Beyond that, it's a matter of individual decision how strong you want to go. You certainly don't want to have a floating pharmacy of narcotics on board with syringes and needles for obvious reasons. But perhaps one of the best compromises here, if you do decide to carry a narcotic for those times when the pain is so devastating that ibuprofen is not going to handle it, would be Vicodin, which is 5 milligrams of hydrocodone in a tablet, so that you don't have the issue with syringes and needles and opiates on board. Muscle spasms I mentioned here because they're quite painful and debilitating. Flexeril can help restore a crew member to mobility and improve comfort in combination with the analgesics. Now, if it looks like I've thrown a lot at you, I have. Fortunately, when you get out there, you don't have to be alone. In fact, I recommend you not be alone. Depending on your skill level, training, and ability to equip yourselves and your cruising area, you may elect to engage an organization that specializes in providing maritime support. And I'll describe briefly 4 of these for you to give you just a capsule summary of what they do. The first is the organization Maritime Medical Access. This is www.gwemed.edu/maritime. This is operated out of the Emergency Department of George Washington University Medical Center in Washington, D.C. It offers essentially 4 components: physician-based triage, which is a physician who is remotely accessed by you at sea on a subscription basis, so you pay an annual or a monthly fee for their availability, and the ability to guide you through the diagnosis and the assessment of the severity of the illness or the injury. That's what's meant by triage. This also offers referral to physician specialists in the event that specialty care is needed. So you're not just talking to an emergency room physician, but somebody who can tap into specialists as well. They have a medical call center that you access, and they will manage, they'll start a file and manage your situation as it develops. And for vessels that have the capability, they have the opportunity to provide remote monitoring of vital signs and statistical information that you would transmit. They're affiliated with the World Emergency Communication Center, which has available 24/7, 365 medically trained operators that will talk to you, and they will patch you or the person taking care of your crew member to physicians worldwide. So not just at GW, but at maybe even an anticipated port of call, which would either be your destination or one that you deviate to. It can provide medical advice. If you have the capacity, video teleconferencing, ongoing case management, and evacuation coordination with an escort, either physician, nurse, or paramedic as appropriate. Referral, of course, to physicians, not only within the GW organization, but worldwide, and training. And they can help you with training for CPR, first aid, and even first responder type training, which would be valuable if you're going to be voyaging offshore and nobody has it. They can also supply the prescriptions or the actual medications for your ship's medical kit, if you're wondering who's going to do that for you. The next organization is MedAir, or MedLink Incorporated. It's www.medaire.com. They also offer 24/7, 365 global access to emergency medical physicians, access to evacuation support. They provide yacht medical kits and equipment, and they'll customize them for your needs. They can provide training and the AED device, as well as first aid and first responder medical training. The World Clinic, started by Dan Carlin about 15-20 years ago, started as part of the Leahy Clinic in Boston. He's now up in New Hampshire. Provides 24/7, 365 access to their physicians and with an electronic medical record, and they'll maintain a prescription medical locker for home or travel. They maintain a database of what they would call first-class physicians in hospitals worldwide that they'll refer you to if that's your need, and they provide evacuation and emergency hospitalization insurance coverage up to $100,000, as well as destination medical planning. Their emphasis is a little broader. They also cover traveling executives that might need remote medical care and evacuation. The International Center for Emergency Medicine, that's www.thefirstcall.com, has a slightly different emphasis. They're geared more toward larger commercial yachts and cruise ships, but they also provide medical supplies, crew training, and they're associated with an organization called Ocean Medical International in Fort Lauderdale. This organization provides a touchscreen tablet PC with a built-in medical knowledge base with real-time vital signs and monitoring, live connection to a 24/7 emergency medicine physician data bank. So if your vessel is set up to have this kind of communication option, that would be something that you could take advantage of. So speaking of which, how do we reach these people? Well, obviously offshore VHF is not going to be our means of communication, except that it may be our primary means of communication with a nearby vessel that has rendered assistance, or with evacuation helicopters. But for long-distance offshore communications, I'll just briefly cover single sideband radio, Inmarsat satellite phones, and SkyMate. Now, single sideband has been the mainstay of offshore communication for decades now. It requires a $3,000 to $4,000 initial cash investment, and if you have access to the ham frequencies, that can only be done with a commercial, or the ham license. But the discourse on the ham frequencies is non-commercial, so you can't conduct business on the ham frequencies, but you can arrange for contact and emergency assistance with those frequencies. Single sideband, of course, has worldwide availability, and the individual availability depends on the propagation. It's, of course, primarily voice, but with the Puncture 2 or Puncture Generation 3 modem and a SailMail membership, which will cost you $250 a year, you can have email. Now, my experience with the Puncture modems is that's about another $1,500. And the SailMail membership, although it does provide, after that subscription, free email, some of the frequencies are extremely busy, and you're limited in the amount of time that you're allowed to have on them. But it does have the advantage of having single sideband real-time capability, so you can get on a good frequency and you can have a reliable email contact. It is slow. These are all slower than what you're used to at home, but they're effective nonetheless. Inmarsat C is available worldwide. Its email, of course, is text only. You're not getting graphics on this. It's relatively expensive at 25 cents for every 32 characters sent, but it is reliable. Most people that are using Inmarsat have migrated to the Mini M. It uses the KVH TracPhone user interface. It's available pretty much worldwide except for parts of the South Pacific. and it's usable for voice, fax, and data. The initial hardware investment is $4,500 to $5,000, and the data use starts at $1.59 a minute, goes up from there. It's about $2 a minute, and it's slow at 2,400 BPS. Satellite phones. Many use these. Many will actually take these and just rent them short term, which is a cost-effective solution for a lot of people. Global Star will give you voice and data at 9,600 baud, but its range is limited to less than 200 miles offshore. But even so, it'll cover most of the east and west coast of the USA and most of the Bahamas and the Caribbean. Iridium gives true worldwide coverage in a little handheld, looks like a cell phone, functions like a cell phone, relatively slow at 2,400 baud. It's voice and data, and the rates begin at $1.50 per minute. And last, SkyMate, which has the availability of email worldwide, again except for portions of the Southern Ocean. It can use your existing fixed VHF antenna to transmit to low orbit satellites, but it waits for the satellites to come into proximity, so there is a delay. This is not necessarily the real-time communications that you can come to expect with satellite phones and Inmarsat and single sideband. It does require dedicated software and an onboard computer. Typically a laptop is used for this. And the way it works is it takes your email and compresses it into packets for transmission, and then it waits for the satellite to come overhead, and then it downloads and uploads whatever messages are available. The charge is based on the number of hours the number of characters that are sent, but you can buy blocks of time, although I understand if you end up with a large amount of data that Inmarsat C is actually cheaper than SkyMate for large numbers of characters. And it has the ability to leave a fax or a voice. It won't be your voice, but it'll be a voice message to a pre-designated land telephone number. So I'd like to conclude by recommending some references to you for further reading. I found them invaluable to my sailing over the years, and some of the topics I've presented here today are sourced in this material. The first is Wilderness and Rescue Medicine. It covers not only land-based medicine, but with some attention to offshore sailing. I think the third edition is about to be updated with the fourth edition coming out this year, so you could look for that. Briggs and McKenzie, their Onboard Medical Emergency Handbook is a very user-friendly guide. It is a British orientation, so the medications and such are not always the ones that we have, but the advice is sound and the strategies in that book are good. The Onboard Medical Handbook by Gill is a little older and a little dated, but it's again a very straightforward, problem-oriented reference. And one of the best out there is Advanced First Aid Afloat by Eastman and Levinson. Not only does it have the up-to-date versions of antibiotics, but also a lot for pediatrics for children on board. So that's the fifth edition. And the last two, the Cornell Boaters Library, Boaters Medical Companion, is now getting to be a little dated. I think it was published in 1989, but it's an excellent small pocket guide. And the Comprehensive Guide to Marine Medicine, Weiss and Jacobs, I heartily recommend this little book. You can put it in your back pocket, and it is just stuffed with information relating to medical issues offshore.
So Lee, thank you very much.
Thank you. It's been my pleasure.
Yeah. Tom, any other last-minute comments?
Just to thank Lee for an excellent presentation, and I'm sure that this is a world-class presentation, and I'm sure that you're doing a lot of sailors a lot of good with it. Thanks, Lee.
Great. Okay.
Thank you.
Thank you, everybody, for attending. We had a nice full house today, and we'll see you at the next webinar. Thanks very much. Have a great day.
Okay. Bye-bye.
Thank you.